Maybe in the meantime, absolutely, it's Vaishnavi. Okay, Vaishnavi, Shilpa, in the meantime, everyone is joining. Did you have any questions from the last session?
No, ma'am.
Have you already done with the musculoskeletal questions?
That is remaining, ma'am. I will do it today.
What about the anesthesia and 1 series questions?
They are done, ma'am. We have discussed the questions.
Okay, it does not have any other further questions in those chapters, right?
Yes, ma'am.
Okay, let's wait for 2 more minutes. Join rest of the persons. Jamil haven't joined yet. Oh, Jamil is there, Kar is there. Nashika is missing. Kashish is also missing. Okay, let's wait till 3:07, then we will start. Samil, any questions from chapter 2 or any previous chapters? Shilpa, Gauri, I'm considering you guys are clear till the anesthesia chapter number 1 and in the chapter number 2 also. Today I'm not well, so I'm not going to start the cardio chapter. Today I will take a little bit easy chapter. So we will start with the radiology. Let me start with the radiology. So the radiology section is 7 series. Here is as we discussed earlier, till the 6th chapter, we have the surgeries, and after the 6th, we have the non-surgical sections such as radiology, pathology, and rest of the sections. So I'm skipping cardiology topic today. We have to do that. So we are going to start with the radiology because that's a little bit easy, and we might wrap up little earlier today. Okay, let's get started. So our radiology chapter starts, or our radiology codes start from 7 series. So whenever any code starts from 7 series that will represent the radiological procedure. Radiological procedures such as X-ray, MRI, CT scan, any nuclear medicine procedures. So these all procedures comes under the 7 series. In this chapter, we have a code from top to bottom, from the anatomical location, based on the anatomical location. Like first we have the codes for the head and neck, then we have a codes for the chest, from spine and so on. And each section we have a code for the first X-ray, then CT, then MRI, then CTA, then 3D. So for each section, we have a same type of diagnostic test. And with the radiology, we can do the diagnostic test as well as the we have the nuclear medicines also here. So from top to bottom, we have the codes. First for the X-ray, let me show you the codes. So you can see here, the first section is head and neck. All the codes are divided based on the anatomical regions. So first we have a code for the radiological examination. These radiological examination means X-ray. So whenever doctor is coming or the provider is doing the X-rays, we have to code the radiological examination for the X-rays. Our X-ray codes are based on the views. All X-rays codes for all the locations, our codes are based on the views. Views are defined by the anterior lateral views, posterior anterior view, and frog view. So we have a different type of view. View means where the everyone is aware about the X-ray views. Okay, let me show you the picture. So X-ray views, X-ray is a oh, images. Okay, X-ray views means this is the X-ray machine. This is the X-ray machine, and if we take the X-ray view from here, anterior lateral view, posterior view. So these are the views. When the machine is at the top and we are reviewing the patient from the upper side of the body from the supine position, that is an anterior posterior view from the supine to posterior. So anterior to posterior, posterior to anterior. This is a patient is located in the posterior. This is patient is in the supine position. And here patient, here we have the X-ray machine and patient is in the lateral position. So if they are reviewing from the side, this is the lateral view. So our all X-rays codes are based on the number of views, and views is based on the documentation. So you can see here we just have the two codes for the mandible, less than 4 view and the complete minimum of 4 view. So if in our case, in our documentation, it was mentioned that doctor did the 3 views, you are going to use 70100. With this series, you are not allowed to use the 52 modifier. With whenever it was mentioned it less than, you are not allowed to use the 52 modifier with these codes. Okay, what is the meaning of 52 modifier? What is 52 modifier, guys? We have already discussed this so many times. Gauri, Samil, Sandeep, Vaishnavi, we just have 4 students here. I need the answer from you. What is a modifier 52?
Ma'am,
Go ahead.
Reduce services like delayed or reduced as per a physician's instructions.
Delayed or reduced. Zamil, can you tell any examples which we had discussed? Like what will be the example of modify 52 instead of just saying reduced? Tell me the difference between modify 52 and modify 53.
Uh, and 52 reduced or delayed by physicians, and
Hmm.
53 I think discontinue the services, like
Very well done, Zamil. Very good.
physicians will, yeah, physician will postpone to that service or that procedure.
Good. So modify 52 is reduced services. Reduced services means when doctor intentionally reduce the procedure which we are going to bill and doctor did not perform the procedure completely, then we are going to consider it as an reduced services. Like you can see here, if they are going to bill the 70110, it needs minimum of 4 views, but doctor did not do the 4 views, then what we are going to do? In this case, we are going to use 70100. But if any case we does not have a different option, we have to build that CPT. So whenever we are billing the extra component, we have to use the modify 52 to represent that our doctor did not complete this procedure. Everyone is clear about modify 52? The best example to understand the modify 52 is colonoscopy. Let's say doctor uh, planned for the colonoscopy. Doctor inserted the scope through the colon, but doctor does not reach to the cecum. Colonoscopy means scope examination of complete colon. So if the colon scope does not reach to the level of cecum, we are going to consider it as an incomplete. And we are not going to build that complete colonoscopy. We just have one code for a colonoscopy 42385. We are not going to build this code for a colonoscopy because doctor did not reach to the cecum. So in this case, what we have to see whether doctor did the colonoscopy till the transverse colon intentionally or non-intentionally. If he intentionally did till the level of transverse colon, we are going to use the modifier 52. Maybe patient have the polyps at the transverse colon only and doctor just want to remove the polyps from the transverse colon itself. Then we are going to use the modify 52 because it is intentionally reduced. The procedure 432 42385 is not completely performed. So we are going to build the modifier, use the modifier 52 to represent that it is intentionally reduced. And the second case is, so let's say doctor inserted the scope and after inserting the scope, patient so after inserting the scope, patient having the hypotension and have some complications, the doctor need to reduce the procedure or doctor need to eliminate that procedure. So in that case, we are going to use the modifier 52. So to see whether we have to use the modifier 52 or modifier 53, we have to see whether it has been intentionally reduced or whether it has been reduced due to the patient condition. If it is reduced due to the complications or the patient condition, we are going to use the modifier 53. Clear? Modifier 52 and 53 is clear to everyone?
Yes, ma'am.
Vaishnavi, can you explain the difference between modifier 52 and 53, please?
Modifier 53 is used when the service is delayed due to complications arrived, or and 52 is used when it is delayed by the service provider.
What does delayed mean? Why we are using delayed word here? Delayed means that doctor is going to do it again one more time or after certain time, are going to give the anesthesia again. What is delayed,
Uh,
Vaishnavi?
Delayed we can use as a it is discontinued for that period. Like they will
For the
decide after.
yes, for this session, for this anesthesia, it has been eliminated. So if it has been eliminated, it has been stopped, then we are going to use the modifier 53. And if we are building a procedure which is not completely performed, then we are going to build the modifier 52. So let's get back to the X-rays. So these codes, first we have our codes for the X-rays, and here we have our codes for views. Our common views are anterior, posterior, posterior, anterior, lateral views. For the pelvis, we use the frog views also. So these are the views, and in the documentation, you will see that which views doctor use to review the or to examine the that body area. So these codes are based on the location, and if a code says, like here, it says less than 4 views. So even though it has doctor did 2 views or the 1 views, and in those cases also you are not going to use the modifier 52. Clear? That we do need to
Yes.
use the modifier 52. Perfect. Um, Next we have the radiological examination. So these all are the radiological examination, X-rays examination. After all the X-rays onto head and neck, we have the CT. We have a particular guideline for the CT here: without contrast material, with contrast material, with and without contrast material. You are going to consider the contrast material only if it has been administered to the intravascular, intra-articular. Sorry, my words are not working today. I'm going to repeat it one more time. Okay. You are going to consider it as an with contrast if it contrast has been administered through the intravascular, that means through the veins and the arteries, intra-articularly through the joint, if the administration of contrast has been done through the joint, and intrathecally. Intrathecal means within the sheath, so within the subarachnoid sheath or in the cerebrospinal fluid. So if the contrast has been administered in these 3 routes, then only you are going to consider it as an with contrast. If the contrast has been administered through the oral method or to the rectum, then you are not going to consider it as a contrast, even though you are able to see that contrast material has been used, like barium enema has been used, or any fluoroscopic contrast material has been used, any iodine containing liquid has been used in the documentation. But you are not going to build that, you are not going to consider it as a with contrast material until unless it has been administered through the intravascular system, intraarticular system, or intrathecally system. Also, in this section, you are going to use the modifier. This contrast topic is clear to everyone. Contrast point is clear to everyone that only we have to consider this as in with contrast and without contrast.
Yes, ma'am.
Perfect. We have this guideline in the book also. So make a note in your book that whenever contrast has been administered through the oral and rectum, we are not going to consider this as a contrast, even though any iodine containing liquid has been used or any barium anemia has been used as in contrast. Still, we are not going to consider it as a contrast. So after that, we have our next topic here, modifier 26 and PC. With the radiological section, you have to use a modifier 26 and modifier PC. Modifier 26 will represent the professional services. and modifier TC will represent the technical component. So whenever there is a procedure, any radiological procedure, there are two components of all radiological procedures, professional services and the technical component. Let's say there is an X-ray. So one person who is the lab technician who is providing the technical component, who is providing his machine or her machine to do the X-rays. And there is another physician who will interpret that report, who is that one is provider or the doctor. What he is going to do? He is going to interpret the report. This lab technician is not allowed to interpret the report because he does not have, or he or she does not have that technical skills, that professional skills, which will allow that person to interpret the report. So in that case, in all radiological services, we have two components. So if we are going to bill for the lab technician, we are going to bill the person who just used or just provided their equipment, their machine. In that case, we are going to use CPT with the modified TC to represent that he does not interpret the report or he does not provide the complete component of the X-rays. And when our doctor just interpreted the report, we are going to use the modifier 26. So if in all settings, in on office settings, our doctor is not going to do the X-rays. X-rays are going to completed by the lab technician only. So in that case, for the lab technician, you will build the same CPT with the modified TC, and for our provider, for our doctor, we are going to build the same CPT but with the modifier 26 to represent that our doctor just interpreted the report. And whenever if we are going to get these services in the hospital and we are billing for the hospital only, so our hospital owns the equipment. So hospital did the X-rays as well, interpreted the report. In that case, we are going to build the global visit. Global visit means we are not going to use the modifier 26 and we are not going to use the modifier TC. Guys, modifier TC 26 clear? If not, please let me know. I will repeat it one more time. Clear, near? Okay. Mm, I will take another example now. Okay. So whenever there is a radiological procedure, we have two type of scenarios in all radiological procedure. And we have to represent these scenarios with the help of modifiers. So if our provider just interpreted the X-rays and not doing the X-ray interpretation, in that case, we are going to use the modifier 26 with our X-ray or any radiological CPT. So whenever our doctor is just providing their professional skills to interpret that report, in that case, we are going to use the modifier 26 to represent that our doctor did not perform the complete procedure. He just did the interpretation. He just did the particular part of that procedure. Modifier 26 is clear to everyone?
Yes, ma'am.
Not clear?
Yes, ma'am.
Okay. Very good. Thanks for responding. Second point, what happened? Okay. Second point, whenever our doctor just provide the equipment, just provide the equipment, not interpreting that report. In that case, we are going to use the modifier TC. So whenever TC means technical component, TC means technical component. So whenever our document is just providing equipment, we have to represent that our doctor did not do any interpretation and did not perform the complete procedure, just provided the equipment. In that case, we have to use the modifier TC. TC is clear to everyone?
Yes, ma'am.
Yes, ma'am.
Good. So till now, we have studied 26 modifier, TC modifier, and 52 modifier. 52 modifier is based on the views. Whenever we are going to build the procedure and doctor did not completed the views, which is mentioned in the procedure, in that case, we have to use 52 modifier, and 26 TC will represent the part of the procedure doctor did. If he just interpreted it, we are going to use the 26. If he is just using their equipment, then we are going to use the modifier TC. Okay, now we will do one question, then we will move further. Okay, I'm going to send one question over the WhatsApp group. Check करना question. Please check the question. We will discuss this question at 3:34. It's already 3:33. Good, Samil. Let's wait for the others' answers too. Gauri, Vaishnavi, answers. Okay, let's discuss this now. In our question, okay, any other answers?
Ma'am, it would be option D, ma'am, because uh, only doctors had performed this. Uh,
Okay, now let's review this together. So, patient is 1 year old and coming for in the doctor's office for the follow-up of an abnormality which was noted on the CT scan. So, patient had the CT scan earlier. Now he's coming to have a chest X-ray, and he's saying that he's otherwise feels well, and here to go over the result of his chest X-ray. And these are the two views: posterior anterior view and the lateral view. There are two views, and in all the options we just have to 71045 and 71046. So I'm going to pull that code. So we have these two codes here. In our documentation, it was mentioned that these two views, PA and lateral, these two are the views. So we are going to use the 71046 CPT, and if we use the 71046, we are rule outing option number B and option number C, and we are left with option number A and D only. And the difference between option number A and D is modifier 26. So how we will identify whether we should use the modifier 26 here or not.
Ma'am, here only doctors have performed that. So no technical components or
Very good, Samuel. So in
and
the
not
documentation,
by professional.
exactly. So in the documentation, it was mentioned that this X-ray is performed in the office only. In the office means in the doctor's office only. So our institute, I mean, our clinic is providing that technical component, as well as doctor need to explain this, they interpret this. So uh, our institute is going to interpret this. So we are going to use both. So we are billing for both the procedures. I mean, both the components of the X-rays. So we have to bill this without modifier. So whenever we are billing the global component, global means both the things, technical component as well as the professional component. Then we have to use the procedure code only without modifier. So the correct answer should be D. Vaishnavi, clear to you?
Yes, ma'am.
Okay, now let's get back. Hmm. So we have the We have already studied about the administration. Now let's start with the foreign body and implant definitions. So sometime we will call foreign body the implant also whenever the implants stop working and stop providing any purpose, then we are going to consider it as an foreign body. An implant is if the if device stunt any device has been inserted from the outside the body to serve any purpose, then we are going to call it as an implant. So the difference between foreign body and implant is if any material, any device is not performing any purpose, then we are going to call it as a foreign body. And if it's it's doing any purpose, then we are going to call it as an implant. Yeah. Let's move further. We have covered. Just give me a second now. Okay. So we have covered X-rays, we have covered CT, and now let's start with the CTA. So with the CT, here we have a CT. If with the CT, if the doctor is doing the 3D also, then we are going to build this code separately with all CTs, okay? Not just with this particular. This one is for maxillofacial. With all other CTs also. So if the CT scan, doctor is doing the 3D rendering, we are going to build 76376. These are the global codes, okay? You have to use these code also. You have to use this code only. The CT scan or the 3D rendering. Next we have CTA. So for CTA, we do have a code for the CTA here. Computed tomographic angiography. This is CTA. And in all the situation, we have a code for a CTA. With CTA, you are not going to build the 3D separately, even though it is performed, still you are not going to build this separately. So with CTA, 76376 and 76377 is not going to report separately. Next, we have a same guidelines for the MRI. MRI and MRA. Let me show the codes for the MRI. So these are the codes for the MRA. With the MRA also, you are not going to build 3D separately. This is inclusive in the MRA. So all MRA scans are with the contrast, without contrast, and with and without contrast. You will consider this with and without contrast when doctor started without contrast first and then take the second imaging with contrast. So the further sequences has been taken with contrast. The first imaging is without contrast. So 3D is always included in the angiography procedure, whether it's a CTA or whether it's an MRA, and you are not going to build the 3D separately with the MRA, and if you are going to build the MRI, then you are allowed to build the 3D separately with the MRI if it is performed in conjunction with the MRI. Next we have after MRI. Next we have the codes for the guidance. Okay, I have a one question here. So here you can see here we have these two codes 71100 and 71101 also. This one unilateral, two views, and this one including posterior anterior chest, minimum of three views. But what if doctor did one view? How we are going to build the one view? We just have these two codes for the ribs. For unilateral, unilateral means one side, either right or either left. So how we are going to build this one view?
Maybe, ma'am, we will use 26 modifier, including this code.
You are saying that we have to use 71100 with the 26 modifier.
My guess, ma'am. I don't know how can we write this like with one view when it is mentioned two views here.
Okay. Any other answers? Like 26 will just represent the professional services. It will not going to represent how many views we have taken. We are going to represent with the procedure CPT only, right?
Yes, ma'am, right. Yeah, that's right.
Mm.
Ma'am,
What
uh,
else what we can do to represent it that we are not going to build the complete procedure?
ma'am, we can use 01 71101.
7. So you are saying we should use 71101 to represent the one view? But our doctor did not perform any posterior anterior chest. Doctor just did the rib X-ray, right rib, right side of the rib X-ray, and only one view. Any other answers? Any other answers, guys? Okay, we just recently studied about the modifier 52. Here we have discussed that we can use this to represent if doctor did not completed the views which is mentioned in the CPT, right? So we does not have any code for the one view, and we just have a code for the two views only. So if doctor just performed the one view, we are going to use the 71100 with the modifier 52 to represent that whatever component is included in this CPT is not performed completely. We did this services reduced. Intentionally, doctor did the one view. So we are going to use the modifier 52 to represent the one view. Clear?
Yes, ma'am.
Yes, ma'am.
Zamir, is it clear? Okay. So remember, we can use the modifier 52 to represent the views. If the complete views is not performed, which is mentioned in the documentation, what we are going to do, we are going to build that procedure only with the modifier 52. The 26 and TC, which just represent the technical and the what are the professional component only. चलो, आगे बढ़ते हैं. So these are the basic procedures which we have in the radiological section. After the X-ray, CT, MRI, MRA, we have the codes for the guidance. I'm going to pull the code for the guidance. These are the guidance procedure. Guidance procedure means whenever doctor is doing any procedure, any surgery, and doctor need to use the radiological method to see inside the body during the procedure intraoperatively, then we are going to use these add-on codes. These add-on codes needs to be used with the primary surgery. Whatever the surgery doctor is doing, we have to build this code with the primary surgery only. So our first code is 96937. So 9369, not 9, it's 7. Sorry, 76937 is for the vascular guidance. If ultrasound guidance is used for the vascular access, then we are going to use 76937. If it is a non-vascular guidance, like any procedure for the non-vascular, let's say for needle placement, for aspirations, then we are going to use the 76942. So 937 is for the vascular access, 942 is for the non-vascular procedure. Non-vascular means non-arterial and veins procedure. These two codes are for the ultrasound, and we have to use these codes in conjunctions with the primary procedure. So based on the medical record, you have to see the most appropriate guidance code which has been performed intraoperatively during the procedure. So first you have to build a procedure, and if you are building the procedure, you have to make sure that this guidance is not included in the procedure. So let's say if the doctor did the arthrocentesis on the knee, and if we check the code for arthrocentesis, just a 606, 606. So in the arthrocentesis, we have a code which include the ultrasound. So if your code includes the ultrasound, then you are not going to build that separately. If your code does not include the ultrasound or any imaging guidance, then only you have to build that separately. You can see here, these are the codes for the arthrocentesis. Arthrocentesis means injecting or removing something from the joints. Arthro means joint, and centesis means doing something with the syringe, puncture. So 20610. This one is without ultrasound guidance, but we do have a code with ultrasound guidance, so we are not going to bill 20611 with 76942 because this code already includes the ultrasound guidance. So whenever you are going to build the guidance codes for ultrasound, we to have two codes, 76937 and 76942. So for ultrasound, we have two codes. We are going to build this code only if procedure does not include ultrasound guidance. So if procedure does not include the ultrasound guidance, then only you have to build these codes separately. If your code already have the ultrasound guidance, then you are not going to build this separately. Next section we have for the guidance, fluoroscopy guidance. For fluoroscopy guidance, we have two codes, 7701 for the vascular access, and 77002 for non-vascular. And for spinal, we have the specific code 77003. These are the fluoroscopy guidance codes. You have to remember, if the code descriptor, the primary code descriptor includes the fluoroscopy guidance, then you don't need to build this separately. If it does not include, then we have to build that separately. So 77001 is for the vascular, 77002 is for the non-vascular. Non-vascular means any procedure which has been performed with a needle, but it is not on the arteries and veins. And 77003 is specific for the spinal procedures. So if it is in spinal procedure, you are going to use the 77003. If it is in vascular procedure, 77001 and 77002 for non-vascular procedure. And you have to remember, if the code descriptor already includes the fluoroscopy, then we don't need to build this separately. Next, we have the CT guidance. For CT guidance, we have a code 77012 and 77011. What does stereotactic localization means? In the last session or last to last session, we have discussed about the stereotactic, right? Any localization from the three sides, from the three dimensions, that is stereotactic. So if CT guidance has been used as in stereotactic localization, then we are going to use the 77001, and any guidance for any other procedure except the stereotactic localization, we are going to use the 77012. So remember one thing, our guidance codes are not based on the location, are not based on the location. Our rest of the CT codes are based on the location. For head, you will find the code under the head section. For the spine, you will find the code under the spine section. For the chest, you will find the code under the chest section. But the guidance codes are not based on the location. In the option, you will get the different guidance code. First, you will get the option for the particular location, and then you will get the code for the guidance itself. So CT, any procedure, fluoroscopy, ultrasound, MRI performed during the procedure intraoperatively as in guidance, then we are going to use the guidance code only. We are not going to use the CT code separately. We have instructions here that we cannot use this code in conjunction with these codes because these codes already includes the CT guidance. So if the procedure description already include the guidance, then we are not going to build that separately. If it does not, then we have to build that separately. For MRI, we have a code 77021 and 22. 77021 for any guidance, for any needle placement, any catheter placements. So if MRI guidance has been used, so if any MRI guidance has been used, we are going to build that with the 77021. We have to follow the same guideline. If the code description includes the MRI, then we are not going to build that separately. We have same instruction here also, like in these codes, MRI is already included. We are not going to build that separately. And guidance codes are not based on the location, anatomical location, and how you will identify whether it's in guidance or the normal X-rays or CT MRI. If any MRI, CT, or fluoroscopy, ultrasound performed intraoperatively to identify the location where we have to insert the needle or where we need to mark the incision, then we are going to consider that radiological procedure as an intraoperative. Guys, you are able to follow now, or any of you have any doubts, any questions? If you are not able to understand, please let me know. I'm going to repeat it one more time, okay?
Ma'am,
Next,
when we have to use this guideline codes other than the normal codes, I am not able to understand.
okay, we have to use the guidance code when it is performed intraoperatively. Intraoperatively means, let's say, doctor need to do the removal of the breast cancer. So, for the breast cancer localization means doctor need to localize that lesion first. So, to localize that lesion, doctor is using an imaging guidance. Doctor need to understand where the location lesion itself. Then only he will proceed with the incision. So we do have a localization device also, like wire clips and everything. But to insert the wire clip and that localization device, we need to see under that imaging guidance, that under the what we call equipment device, we have to see under the device where that lesion is. So that is guidance. So if during the procedure, doctor is using any device, any radiological guidance to uh, understand where we need to insert the needle, where we have to mark the incision, then we are going to consider this as a guidance. Is I'm able to answer your question? Not yet. Okay.
Yes, ma'am.
Are you able to understand the guidance means? Can you explain to me once?
Like ma'am, you gave the breast cancer example. So before performing any surgery, when doctor has to find out the particular lesion, where is that lesion? So to
Mhm.
find out that lesion to insert any needle or anything, so
Mhm.
then we use this guidance to find the particular location of the lesion.
Very good. And if it isn't before, So we are going to bill based on the location. If it is an intraoperative means during the procedure. If it isn't during the procedure, in that case, we are going to consider it as a guidance. If it is before the procedure, then we are going to build that based on the guidance only. Okay,
Okay, ma'am.
let me see if I can find any specific question in regards to this so that we can do the question together.
Ma'am,
Mm-hmm.
ma'am, does it not include any diagnostic purposes?
No, guidance does not include the diagnostic purpose. If it is for the diagnostic purpose, you have to build the normal codes based on the location, which we have seen earlier. So if any imaging guidance has been used during the procedure, then only you are going to consider it as a guidance. Okay.
Okay.
Doctor cannot perform the surgery without diagnosing it, right? So if it is for the diagnostic purpose, you have to build based on the location. If it is non-diagnostic, it is during the procedure, then you have to build that with the guidance codes. Just give me a second.
Okay.
I'm a particular example so that we can understand this better. We have the options in 16. But I have sent one question over the WhatsApp chat. It's 4-6. Try to solve it by the 4-8 or 4-9. So in this question, doctor is doing ultrasound guided radio frequency ablation. Ablation means to burn the lesion with the heat or any radio frequency energy. It's 4-8. We will discuss this at 4-9. Okay. Any answers? Guys, I just received the answer from the Gauri. But about others? Zamil, Vaishnavi. Okay. We just had one photo. Hmm. Correct answer should be D. Zamil, are you able to complete this question?
Yes, ma'am, I'm doing.
Okay. Jamil, shall we discuss this or did you need few more minutes? Okay, starting. So in our question, it was mentioned the doctor is doing the ultrasound guided radio frequency ablation. So let me show you the radio frequency machine. So whenever doctor is doing the radio frequency ablation, doctor need to use any particular probe, and with the help of that probe, doctor insert the radio frequency energy in the patient's body. These are the probes, okay, in the patient's body to uh, shrink the lesion or to destroy that particular lesion. That is a radiofrequency ablation. And to identify the exact location where we have to insert the probes. So let's say from under the ultrasound guidance, we have to see where these needles are heading towards inside the patient's body. So for the radiofrequency ablation, we will use ultrasound guidance. So in our question, it was mentioned it is other than liver. So it is not on the liver, not on the kidney, and neither on lung. So we have to use 3 series when any procedure performed on the lung. So our first answer has been ruled out. We have to use 5 series when any procedure performed on the kidney. So the second option has been ruled out. And if any procedure performed on the liver, then only we have to use 4 series. So the third option A, B, C has been ruled out. In this case, we have to use 76940, which will represent ultrasound guidance for the ablation, for tissue ablation, that with the help of energy, that lesion, that tissue has been ablated, and to represent the location which is not mentioned here because it is just mentioned other than liver, kidney, or lung. Where the location is, it is not mentioned here. So to represent the location which is not mentioned, we are going to use unlisted code 76999. So the correct answer should be D instead of the A, B, and C. Vaishnavi, clear to you?
Yes, ma'am.
Good. So now we are good at the guidance part. Let's move further. So our guidance part is completed. After the guidance, let's proceed with the diagnostic ultrasound. Our ultrasound codes are based on the complete and limited, as well as OB and non-OB. Let me put those first. Complete and limited. Okay. These are the ultrasound guidance codes, not guidance, diagnostic ultrasound codes. So whenever doctor is doing any diagnostic ultrasound, we have to make sure that all the diagnostic ultrasounds are saved in the system, in the EHR. Then only we are going to build a diagnostic ultrasound. So the first guideline is we have to make sure that we have the permanently recorded images with the measurement in the EHR. Then only you are going to build the diagnostic ultrasound. If doctor just did the ultrasound but missed to save these images or the measurements permanently, then we are not going to build the diagnostic ultrasounds separately. If it is uh, saved, then only we are going to bill. If it is not saved, then we are not going to bill it, even though it is performed. So what happens in the diagnostic ultrasound? The ultrasound works on the sound waves. So ultrasound. So these works on the sound waves to visualize the internal structure such as muscle, tendon, and organs. For the bones, we use the fluoroscopic guidance and the X-rays. But for the soft tissues such as muscles, tendons, and organs, we use the sound waves. So when the sound wave interact with the internal structure and come back to the uh, diodes or the electrodes, then we are going to consider it as an ultrasound. In these ultrasounds, images needs to be captured to measure the size of the baby or movement of the baby and the functioning and the structures of the baby, whether we do have the level of the ultrasounds also, so which we will learn later. But with the help of ultrasounds, we will just visualize the size, the movement, the structures of the patient's babies or the fetus. And we have a three different type of scans: A scan, B scan, or M mode. So A mode, B mode, or M mode also. So if it is in real time scan, A mode means amplitude mode. We have a course here. Let me show you. This is A scan. A scan means amplitude mode only. So amplitude mode only means only one dimensional scan. Basically, these will use for the ophthalmic ultrasounds. So let me mention it is here amplitude. It is one dimension, okay? One dimension. Next we have a B mode. B mode means brightness. A means amplitude. B means brightness mode. Brightness mode is a two-dimensional scan, and M mode means motion mode. This is a one-dimensional scan, but it will show the movement of the moving structure such as heart or any movement of the fetus. So M means motion, B means brightness, A means amplitude. And even the ultrasound is also available in the 3D and 4D scans also. So 3D and 4D are the different high level scans. So we have to build the ultrasound only whenever the scans or the images has been captured or the saved permanently. If it is not saved permanently, we are going to consider it as an we are not going to build that separately. Okay. Next, A mode, B mode, and M mode. Also, a few ultrasound codes are based on the limited and complete. So let me show you the limited and complete. You can see here, this is complete, this is limited. Under this one is for the breast. For the chest also, this one complete. This one is for the retroperitoneal, complete and limited. So our codes are based on the complete ultrasound codes basically. Ultrasound codes are based on the complete and limited. We are going to consider it as unlimited. If we talk about the abdomen cavity, if this is an abdominal cavity 76700 retroperitoneal. To consider it as incomplete, we need the 8 elements. 8 elements. These elements are mentioned here. Here are the elements. Whenever, with the help of ultrasound, liver has been visualized, gallbladder, common bile duct, pancreas, spleen, kidneys, upper abdominal aorta, inferior vena cava. 1, 2, 3, 4, 5, 6, 7, 8. When all these elements, all 8 elements has been reviewed, then we are going to consider it as an complete. If less than 8 element has been reviewed, then we are going to consider it as an limited. So for complete ultrasound for abdomen and retroperitoneum, we must need to review that how many areas has been visualized. If it is 8 and more than 8, we are going to consider it as incomplete. If less than 8, we are going to consider it as an limited only. Same we have this in the breast 76441, 76641 and 76642. And here we have the definition of the complete and limited. You will consider it as incomplete if it reviews all 4 quadrants as well as retroaerial region, and if any of the quadrant has been missed, you are going to consider the limited. So four quadrant means upper outer inner quadrant, upper outer quadrant, lower outer quadrant, lower inner quadrant, as well as the retroaurodial lesion. Then only we are going to consider it as an complete, else we are going to consider it as an limited only. Everyone is clear in the difference between limited and the complete? For the ultrasound, for the diagnostic ultrasound, you have to make sure that you will calculate the regions. You will see that how many areas has been visualized. Then only you can determine whether it is complete or limited. Any questions so far? Any questions, any doubts in complete and limited?
No, ma'am.
Okay. Let, I have a one question here, okay? So let's say on the same date, doctor did the abdominal ultrasound. This is a scenario, okay? So doctor did the complete, I'm mentioning complete, that means all element has been reviewed. So on the same date, doctor did the complete ultrasound, and after the ultrasound, doctor removed the appendix, so performed the appendectomy, and after doing the appendectomy, he again did the ultrasound on the same date of service. It should be on same date of service, okay? So on same date of service, same session, doctor again did the ultrasound to review the appendix. So it is a limited ultrasound for the abdomen itself. Limited USG for abdomen. So how we are going to do? You just need to skip the appendectomy because appendectomy is billed by the surgeon who did the appendectomy. But we have to build the ultrasound, and on the same date he did two ultrasound, one complete and another one limited. How we are going to build this? Tell me how we are going to build this. Two ultrasound performed in the same session by the same provider on the same date of service.
Ma'am, can we add codes for both complete and incomplete?
Yes, we can add. So let's say we have coded 76700 and 76705. We are going to code both the codes because doctor did both the procedures. So Corey, do we have to use any specific modifier in conjunction with these procedures to represent that these both are performed at the separate separate times instead of just
Yes,
billing it without? Yes, what will be the modifier for that?
um, that I don't remember. But there is a modifier I know. Like there is a for a modifier that a same doctor do two different procedures, but I don't remember which one.
Okay, I'm going to give you the hint. You modify 51 and 59. Just go and read the description of 51 and 59 and tell me which one is the best one for this scenario.
Okay, ma'am.
Modify. Everyone just go and read the modify 51 and 59.
Ma'am, 51 modified.
51. Zamil, what is the difference between 51 and 59?
51 means, ma'am, there will be a multiple procedures so that are performed by the physicians on the same day.
Okay, multiple procedures.
Yes,
And
ma'am.
59?
Uh, Different, like two different procedures or two different sessions.
Two different sessions. Okay, any other answers? Zamil, per Zamil, we should use the 51. Any other answers? For the modifier for this situation, 51 and 59?
Ma'am, 51 seems more appropriate than 59.
Okay. So the difference between modifier 51 and 59. 51 represents that the multiple procedure has been performed. Okay, multiple procedure. Multiple procedure on with the same incision but the different area. Let's say one procedure performed on the gastro, that means stomach, hepatic, liver, and the kidney through the same incision. Doctor need to do any particular procedure. So with the same incision, he is doing a procedure on the gastro, hepato, kidney. Different areas, different sites, and completely different procedures. Okay. In that case, we are going to use the modify 51 with the secondary or tertiary procedure to represent that only with a single incision we did this procedure, and we does not need to make any separate incision for the hepatectomy or any hepatic procedure or any kidney procedure. So modify 51 will just represent that multiple procedure performed on the different site. Multiple procedure, different procedure performed on the different site. Whereas you need to use the 59 modifier to represent distinct procedure. When you have to represent it's a distinct procedure, when you are going to build the component of the major procedure separately, then you have to use the modifier 59 to represent that I know this is a component, but this is a distinct procedure, hence we are billing it separately. Like in this case, if we are going to bill complete and limited for the same patient uh, to the same insurance, insurance will tell us that limited is already included in complete and we are going to pay only for the complete. Limited is going to deny. Why? Because it is already included this component, this single organ or quadrant is already included in this. So doctor insurance is not going to bill this. So to tell the insurance that we know that this is a component of the previous procedure, but this procedure performed distinctly, separately, we have to use the modifier 59. So the major difference between the 59 and 51, 51 is totally different procedures. It will just show you that these are not the component of each other. You have to use 51. When the procedures are not the component of each other, then you have to use the modifier 51. But if you are going to build a component of each other at the same time in the same claim, then you have to use the modifier 51. So here you have to use the modifier 59 instead of the 51. Clear?
But ma'am, it also says that they're not ordinarily encountered or performed on the same day by the same individual. What does it mean?
Let me open the appendix A. Just give me a second. You are referring appendix A only, right?
Yes, ma'am.
Yeah. Can you tell me the page number, please?
1023.
1023. Which line? Yeah, this one that are not
No, ma'am, more below than this. On next page, it is there.
not ordinarily encountered or performed on the same day by the same individual, right? This one?
Yes, ma'am.
Okay. This is saying the same thing. Like like in our case, we are going to build the complete ultrasound and the limited ultrasound on the same day. It is not ordinarily not usually performed on the same day, right? If the doctor is doing the completed ultrasound, he does not need to do the limited separately because he already reviewed all the diagnostic portion, all the elements in under the complete only. So to represent that we know that these two procedures are not ordinarily encountered or performed on the same day by the same individual. However, in the different unusual circumstances, doctor did this procedure, so we are going to build this. Okay, Gauri? Let me take one more example. So whenever doctor is doing any excision, so if he did the excision, in the excision we studied that simple repair is always included because if doctor did the incision, he need to repair that, right? It is included. That's the only reason we are not going to bill that separately. But if excision is performed on the right hand and simple repair is performed on the left hand, so in this case, we have to build both the conditions because they both are at the distinct site. So to represent that we know that simple repair is a component of the excision, but this performed at the distinct part, or this is a completely distinct procedure. So we are going to build this separately. Clear?
Yes, ma'am. But ma'am, earlier in the example you included that the gallbladder was sorry, appendectomy was performed, and it
Mhm.
will become under limited procedure. So with that,
Append-
with considering that we can,
mhm. Go ahead.
so with that it will be different condition regarding this.
That's the only reason we are using 59 because it's an exceptional condition. It's an unusual circumstance that after doing the appendectomy, doctor is redoing that procedure, that ultrasound. So we are going to build that procedure ultrasound separately with the modifier 59. So let me explain 51 and 59 one more time. So 51 will just represent that multiple procedure by the same individual in the same session on the different site has been performed. So modifier 51 will not represent the it's not based on the component based, because these are the different sites, not on the same site, right? Completely different procedure insurance will allow. And with the modifier 51, we will just say that only one incision has been marked. So insurance will just reduce the amount of the secondary or tertiary procedure with few percentage, okay? So 51 will just represent that only one incision has been marked. Whereas 59 needs to be used when we are billing two services which is not allowed to be billed together, that are not allowed to be billed together. So if we are billing two services which is not allowed to be billed together at the same time, in that case we have to use the modifier 59. Like in our case, we are not allowed to bill the complete and limited of the same site for the same patient. Sorry, does that make sense?
Yes,
Yes,
ma'am.
ma'am. Now I
Understood.
Clear?
Yes,
Like,
51 is like more normal thing that can be happen twice in a day, but 59 is exception that is happening
yes,
twice in a day. So that time we go with 59.
very good. So in this case, the example which we were discussing, yeah, um, that if the complete and the limited is performed in a rare situations. So to represent the insurance that hey, we know that we cannot bill these two services together, but to tell the insurance that these two are the distinct procedure, doctor did this procedure twice for the different medical necessities. So we are going to build this with the modifier 59. This point is clear to everyone, right?
Yes, ma'am.
Modifier,
Yes, ma'am.
perfect. Good. So now let's move further. Okay, one more thing. If the ultrasound is performed for the vascular structure, so in that case, we have to build the Doppler also. So for that Doppler, we have a code from series 93. For the Doppler, we does not have the code for the from the radiological section. For the Doppler, we have the code 93880 and 93990. We will discuss these codes when we will in the medicine chapter. So for Doppler, we have these two. Just make a note in your notebook. Now let's move further. I have a one more question here. So here you have a description of the seven. You have to follow your books, okay? So here we have 76770, and in the 76, this one is retroperitoneum, okay? Retroperitoneum means back side of the peritoneum area, peritoneal area. So 76770 means this is a complete retroperitoneum ultrasound which visualize kidney, abdominal aorta, common iliac artery, inferior vena cava. So one, two, three, and four components. Okay. So when these four elements has been reviewed, we will consider it as an complete. But in our case, let's say in our situation, Doctor 76770. Okay. Doctor did the ultrasound of both kidney and bladder, the complete bladder ultrasound, as well as kidney ultrasound, so that he can rule out any urinary pathology, because retroperitoneal is for the urinary pathology or urinary tract pathology. Then what should be the code? Do we have to use the limited or do we have to use the complete? Both kidney and the bladder.
Complete, ma'am.
Complete. Any specific reason that why we should use the complete?
Ma'am, urinary tract pathology suggests that complete evaluation includes kidneys and bladder also.
Perfect. So you have to make sure if both kidneys and bladder has been reviewed to identify any urinary tract pathology, then we have to use the 76770. If only kidney or any only bladder has been visualized, then we are going to consider it as an limited. Okay, let's move further for the pelvic ultrasound. Next section we have, I'm skipping the spinal because we just have the one code in the spinal. Next we have the pelvis. In the pelvis, we have two types of code, OB and non-OB. Okay, so in the pelvic, we have two type of codes, OB and the non-OB. OB means those codes for the pregnant ladies, and non-OB means for the female and male both when the pelvis has been examined. So let's start with the OB first. Our OB codes are based on the trimester. First trimester means 0 to 13.6 week of pregnancy, that is first trimester. 14 to 27.8 second, and 28 to delivery, third trimester. So these codes are based on the trimester as well as number of fetus. So if it is an approach also. So if it is trans-abdominal approach, that means through abdomen, trans-vaginal approach through vagina. So our codes are based on the trimester. Trimester as well as fetus. Fetus is gestation. So that it means if there are twins, so if twins are there, that means we have to use the add-on code also to represent that there is a twins. So this add-on code will represent additional gestation or additional fetus. So trimester, fetus, and in the last you have to review the approach. So our codes are based on the approach, trimester, and the number of fetus. If there is an additional fetus, we have to use the add-on code to represent that additional fetus has been evaluated or examined during the ultrasound. Also, we do have a code for the BPP, that is biophysical profiles, under the fetal ultrasound itself, so under this section only. So in the BPP, we will review the amniotic. Let me open the code. Amniotic fluid, little breathing. Let me open the code just a second. This is the biophysical profile, fetal biophysical profile with the non-stress testing. So in the biofetal physical profile, this includes the information of the amniotic fluid, fetal breathing, fetal tone, and the baby gross body movement. So this profile can be performed with or without non-stress testing. Non-stress testing will represents whether the patient baby is reactive or non-reactive. So all other codes includes this information. You can see here and amniotic fluid volume and the growth parameters are also included in the ultrasounds, but in the biophysical profile it is not mentioned here. However, these things are included. If it is with NST, we are going to build 76818. If it is without NST, it is 76819. So we just have a two codes, 76818 and 819. If the BPP assessment has been performed for the additional fetuses also, then we are going to build this code separately because here we does not have any add-on code for the gestation. And also this code is not based on the trimester also. So what we are going to do, we are going to build 76818 and 819 with the modifier 59 to represent. That's because patient have the additional fetuses. So we need to do FBPP again for the additional fetus at the same time. So we are going to use the modifier 59. And clear till now? So the basic thing, OB and non-OB. OB ultrasound are for the pregnant, codes divided based on the trimester, approach, as well as the fetus. If the additional fetus has been reviewed under the ultrasound, we have the additional code for each additional fetus. This gestation means fetus, okay? This gestation means fetus, huh? And we do have a code for the FP, FBPP, fetal biophysical profile. And this one is based on non-stress testing and stress testing. If two fetus has been, or more than two fetus has been reviewed, you have to build each unit for each fetus. Let's move further. Next section we have for non-OP. Non-OP ultrasound includes the transvaginal ultrasound, sonohystrography. Sonohystrography means with the help of ultrasound base, sono means sound, hystro means uterus, graphy means graph. So for the transvaginal ultrasound, a sonohystrography, non-OP pelvic ultrasound. We have these codes here. Let me pull the codes. So you can see here, the first one is ultrasound transvaginal. Transvaginal means through vagina. So if the ultrasound is used to look at the female reproductive organs such as uterus, ovaries, cervix, vagina, then we are going to consider it as a transvaginal. Sonohystrography, next code, this one, sonohystrography. Sonohystrography is an ultrasound of uterus. Is the ultrasound of uterus where the saline infusion, uh, saline infusion has been inserted to the uterus into the cervix, and then this procedure is need to do to evaluate the symptoms such as abnormal uterine bleeding or infertility or any abnormalities in the uterus linings. Then we have to do this sonohystrography. This include Doppler, so we are not going to build this Doppler. And to introduce the saline infusion, that means the saline, the fluid infusion into the into the uterus. So that introduction we are going to build that separately. That administration we are going to build that separately with the code 58 340. Then we have the pelvic ultrasound codes, the normal pelvic ultrasound codes. This is non-OP. If it is OP, we have to quote the previous one. This one is also based on the complete and limited. And to understand the difference between the complete and limited, you have to follow the elements documentation, that all the elements has been mentioned. If all the elements has been covered, then we are going to consider it as completed. And if only just for the follicles, like if the patient have the PCOD and she just came for the follicles ultrasounds, then we are going to consider it as a limited only. Next, we have the genitalia, the normal one. Next, we have the ultrasound for the extremities. So, for the extremities also, we have the code for the disease. Okay. I'm skipping the extremities because these are the word-to-word code. So, I'm skipping the ultrasound for the extremity. Now, I'm moving to the breast mammography code, okay? Because we are left with only 6 minutes. So I'm picking the breast mammography. 77065. Okay. So for the breast mammography, we have the code 77065, 66, and 67. And this code includes the computer aided detection. So we are not going to build the computer aided detection in conjunction with the 77065, 66, and 67. In these codes, we have to use the modifier GH and GG. GH and GG. So we have to use the GH when we are going to bill for the diagnostic mammography only, and GG when we are going to bill for the screening as well as the diagnostic. So the difference between these two, let's say if the patient is scheduled for the screening and the physician found some abnormality, and then he converts that procedure, that screening procedure, into the diagnostic procedure, and then just remove the any abnormality there, okay? Then we are going to use the modifier GH. So if we are going to build the diagnostic only, okay? Diagnostic only. So patient is scheduled for the screening, but during the screening procedure, he found some abnormalities, which turns that screening procedure into the diagnostic mammogram because he found some abnormalities. So we are going to build the modifier GH. Next we have GG modifier we need to use. Let's say if the patient is scheduled for the screening. Screening means till now patient does not have any illness or any conditions identified yet. So let's say if the patient is came for the screening mammography only, and doctor found some abnormality, and after that abnormality, after the screening mammogram, after the screening mammogram, he did some procedure. He did one more procedure, like he found some abnormality and then he did one more procedure on the same day. So with the diagnostic study, you are going to use GG modifier. So if it is purely diagnostic study means the doctor is doing any procedure under this at the same time of the mammogram. So then we are going to build the diagnostic modifier GG, and if patient came for screening and at the same session he is not doing any other diagnostic mammogram, at the same under the same mammogram he converts it into the diagnostic, then we are going to build the GS. That means this is a completely diagnostic procedure. But if doctor is billing screening as well as the diagnostic mammogram, then you have to use a modifier GG with the diagnostic mammogram. So since 2018, we have to use this GG modifier with the mammography, as we were not using before that. So before 2018, we were not using the GG and GH modifier with the screening mammography. So that how you will identify, like you can see here, 77065 6. These two codes are for the diagnostic mammography. You can see here, these two codes are for the diagnostic mammography. But the 67 is for the screening mammography. If you are billing both screening and the diagnostic, then you have to use the modifier GG with the diagnostic one. And if screening turns out to be diagnostic only and you are going to bill the diagnostic only, then you are going to bill 77065 and 66 with the GH modifier. Any doubts here? Any doubt, guys?
No, ma'am.
No,
Okay. Next topic, bone joint studies. So in this section, we have a code for the DEXA. 7708. This is DEXA. Our DEXA codes are based on the axial skeleton and the pentacle skeletal. So with the DEXA performed on the axial 77080 and appendicular 77081. So this is basically a bone density study, which will mainly perform to identify the osteoporosis condition or osteopenia condition. And with the help of DEXA, we can get the T scores. So if the T score is between -1 to 2.5, it will lead to the osteopenia, and then if it is below 2.5, we are going to consider it as an osteoporosis. So these DEXA scans are based on the skeleton's location, appendicular or axial, and we have to build this based on the site. Okay, you can see here one or more site. That means if exercise performed on the hips, pelvis, and the spine, all three location. Okay, still you are going to build this only one time. Okay, you have to build this only one time. Why? Because this is complete for the axial skeletal. This is for the axial skeletal. Okay. So let's move further. Next important topic is nuclear medicine. Just give me a second. Okay. So next main topic is nuclear medicine. So first one is radiation oncology. So nuclear medicine is a branch of medicine which deals in the use of radioactive substance to diagnose or to treat the neoplastic conditions. So basically, radiation oncology is a multidisciplinary medical specialty. Here we need to use the physician, physicist, and nurses, scientists, computer scientists. So many people are included in the radiation oncology department, where we have to start with the consultation, we have to do the clinical treatment planning, we have to see medical radiations physics, any dosimetry treatment devices, stereotactic radiation treatment delivery, or neutron beam treatment delivery. So these are the sections of the radiation oncology. This is a little bit big topic. So what we will do, we will complete this radiation oncology topic in the next session. And in the radiation oncology, okay, we will do this in the next session. So you can do one thing for the next session. You can read about the radiation oncology, that what all domains are included in the radiation oncology, and what is the difference between the radiation treatment planning, radiation simultaneations, and what should be the best temperature where we have to give this radiology treatments. So just take a moment and go through with the radiation oncology section before the next class. So in the next class, we will discuss about the nuclear medicine, that radiation oncology. Any questions so far?
Ma'am, have you shared the answers of musculoskeletal questions?
I think I do, but let me check. Just give me a second. No, I didn't. Let me share that right now. Just give me a second. Musculoskeletal. Gauri, I have to find the answers. I will share the answers after half an hour. Okay.
Sure, ma'am. No problem.
So
Thank you.
thank you. So I'm going to send the questions for this series also. I know that we haven't covered the nuclear medicine part, the radiation oncology part. You can skip the questions for the radiations oncology. We will discuss this in the next session. And you can do the assignment for the 7 section or 7 series also. Okay. Now let's wrap up the session. Thanks everyone. Thanks for your time. Any other questions though? Okay. Thanks everyone. Bye bye.
Thank you, ma'am.